Good afternoon. We'll go ahead and get started. I'm Jim Christina, Executive Director and CEO of the American Podiatric Medical Association. I want to welcome you to this congressional briefing on diabetes and latest advancement in diabetic limb salvage. APMA is the national association representing the vast majority of America's foot and ankle physicians and surgeons and the millions of patients for whom they provide care. You may know that DPMs receive basic and clinical science education and training comparable to that of allopathic and osteopathic physicians. This includes 4 years of undergraduate education, usually pre-medical, focusing on life sciences, 4 years of graduate study in podiatric medical school, and then at least 3 years of postgraduate training and a hospital-based residency training program. As such, doctors of podiatric medicine are licensed by the state to prescribe medicines and perform surgeries independent of any collaboration or oversight requirements. As the prevalence of diabetes continues to grow in America, it is more important than ever to raise the awareness about diabetes, stand with those battling this life-threatening disease, and recommit to preventing diabetes and reducing its life-altering complications. Every family in America is impacted by diabetes in some way. Both the human and economic toll of this devastating disease will continue to worsen until action is taken. In the United States, nearly 30 million Americans have diabetes, and an additional 86 million have pre-diabetes, placing them at high risk of developing the disease. Not only has the number of people afflicted with this disease skyrocketed in recent years, but so too have the costs. The diabetes epidemic cost our nation more than $245 billion in 2012, and 1 out of every 3 Medicare dollars is spent on a person with diabetes. Those with diabetes are at increased risk for heart disease, vision loss, and amputation of limbs. In fact, diabetes is the leading cause of lower limb amputations in the United States. Today, you'll hear about some of the remarkable things that podiatric physicians and surgeons are doing to save lives, save limbs, and save healthcare dollars. I hope you will keep in mind that there are a number of things policymakers can do to aid in the management and care for those with the disease so that preventable chronic conditions do not continue to become even greater cost burdens to our public and private health programs. Again, I want to welcome you to this timely and important briefing. APMA looks forward to working with you all to raise awareness about the need to tackle diabetes head-on and to support legislative solutions that would improve diabetes research, education, and treatment. I'd like to introduce the first of our speakers today, Dr. David Armstrong. Dr. Armstrong is a professor of surgery and director, Southern Arizona Limb Salvage Alliance, also known as SALSA, at the University of Arizona College of Medicine. Dr. Armstrong.
Thank you for that golf clap, and I'm going to switch over here. Thank you, Jim. All right, can you all hear me? Good. All right. If you can't, then just keep eating. And I'm sure it's a gustatory delight. By the way, this coffee is spectacular. It's for that vending machine. You guys know about that? I just want to give a shout out. Anyway, listen, it's a pleasure to be here today, and we're going to talk about something that you guys, I am certain, have never even thought about, which is the friggin' feet in diabetes. I don't think that most people would even think to pay much attention to this area, but hopefully after this business, and certainly after the next two folks, you'll care about it a little bit more, I'm pretty well sure. And I want to thank the folks from Diana DeGette's office and Renee Elmer's office for working so hard to put this together, along with APMA and many others. This is really a lot of fun. And so thanks for letting me play hooky from a crazy day in clinic in Tucson, Arizona as well. So what we're going to talk about, and by the way, all these things, if you want any of these data, I think there might be in the packet, but if they're not in the packet, we give all this stuff away. It's very much open access. We give all the slides away and all these data, and they're all available there. You can follow us, do whatever you like, or not. But what we're going to talk about in our brief time together today is kind of the big picture, not only about the end of the body and feet and diabetes, but really rather kind of a larger picture. We're going to try to ask, why should we care about any of this stuff? Why should we care about this rise of non-communicable diseases around the world. Bless you. Why should we care about how's that going to affect policy, and how's it going to affect our families and the folks in our constituencies. After that, we're going to talk about some really good news, which is the evolution of teams to care for these. People talk a lot about teams and team science and team medicine, but a lot of people talk about it. Very few people do it. And when it's done, you're going to see examples of it being done right here in Georgetown with Dr. Steinberg. It really can make a difference. Coinciding with that is the evolution of technology, and it's an exciting time to be doing this right now, frankly. So I'm going to start not with any data or a histogram or a picture of something impressive. I'm just going to start with a year. This was a few years ago. People on the Hill were dealing with trying to keep our country alive economically. That's probably what everyone was thinking about here. But I would argue that in a public health sense, this was probably the most important year in any of our lifetimes, and as a species. And why do I say that? Because it was the first time in the history of us. By the way, you guys can see okay? Okay, good. That it was the first time in the history of us that more folks died of non-infectious diseases, of NCDs, non-communicable diseases, than from all the plagues in the world combined. And that doesn't seem like a very big deal, but it is. It's a big deal. And what are the big three non-communicable diseases? Cancer, cardiovascular, you guys are all on it. Cardiovascular disease, what else? Diabetes, and if you want to add the fourth, just add it in. And give props to lung disease. That's another one. But the big three are what we already mentioned. So these big three surpassed all the infectious diseases that had ever come before that year. So a switch was flipped. And that same year, one of those big three, it surpassed HIV/AIDS in terms of death, since HIV/AIDS became an endemic and epidemic in parts of the world in the 80s. And later. So this is a big thing now, not only in the U.S., but frankly around the world. And it's affecting not just dollars, but it's affecting policy. It's affecting how we take care of us, our parents, our grandparents. As we age, we are literally victims of our own success as we kind of move on from disease, if you will, to decay. So we know diabetes is a big deal. You already heard all these great data from Dr. Christina about the fact that this is costing us between $250 on the small end and $300 and something billion, give or take, and not even including loss of work and productivity and other things. But let me just tell you, remarkably, the most common reason that someone's going to end up in hospital with diabetes is why do you think? Well, you're like I think you get this, already. You're in the front row, like gunner students. But you'd think heart disease, but remarkably, it's your foot. So the bottom line is that these foot complications at the end of the body that no one thinks about, that are covered up with shoes, are common. They're complicated, and they cost a lot. They're costly. That's all very alliterative. But let's kind of hit each one of those briefly as we kind of move down into all this. And move into what we can do about it together as a big family. So if we look here, if we look at the population of the U.S., we see about 30 million, give or take. Now it's a little more, maybe, with diabetes. About half of those folks have what is called peripheral artery disease, or it's like heart disease, but in your legs, in the longer vessels. And then half of them also have neuropathy, and that is basically losing the ability to feel pain. One of my mentors used to say, "Pain is a gift from God," and it really is. And people can wear a hole in their foot like you or I would wear a hole in a sheet or a sock, and that hole is called an ulcer, diabetic foot ulcer. And after that happens, about half of those folks get infected. Once that happens, about 20% of those infections lead to some form of amputation. That's why there is an amputation every 20 seconds around the world, just so you know. Every 30 minutes someone loses their leg because of a landmine, every 20 seconds because of their foot in diabetes. So anyway, it's a big deal, and no one thinks about it because it's silent. And look at this. I wouldn't have thought about this. I told you this. I kind of buried the lead earlier when I told you this, but we just presented this in The Hague to the World Health Organization, a consultative body last year, we looked at about 540, give or take, million outpatient diabetes visits in the United States over a 5-year period in the last decade. And if we were betting on the most common reason that people would be admitted to hospital, it would be for heart disease. If you wanted to bet the mortgage on something, you'd bet on cardiovascular disease. It's just such a big killer in all the developed world. But look at this. It's remarkably the greatest risk for hospital admission amongst these 539 million outpatient visits was for a foot ulcer. And that drives not only complexity, but cost. Because as you guys all know, if you ever work in health policy, conservatively, 2/3 of the direct costs of care are borne on the inpatient side of the equation. It's probably more like 3/4 for a lot of these problems that we see as we look at these data. So that's costly, but let's continue with this. And it's a little cheeky to compare one thing to another in a public policy kind of setting, but we all care about cancer. All of us probably have someone in our family that's passed away, or God forbid has cancer, or is struggling with it or has. So let's talk about and try to compare these sorts of things. We already looked there at some of the commonality of the diabetic foot. Let's look at cost, and the cost now for taking care of the lower extremity in diabetes is more expensive in the United States now than the 5 most expensive cancers in terms of direct costs. Now there are plenty of people, even during recess, on the Hill talking about the war on cancer right now, and they well should be. But I can guarantee you, few here are the only ones talking about feet in diabetes. And so that red line there on the left of this histogram is this sort of silent, sinister problem. I don't think you can define it any more or any less so. It's quite extraordinary. So that's further with the cost. Now what about the real cost, which is in terms of morbidity and mortality? These are the most conservative numbers that we can put together, not the most aggressive. And what we see here is that when someone has an amputation or pre-existing peripheral artery disease or a wound on their foot, an ulcer, as we talked about, these things are at least as bad in terms of 5-year, 3-year mortality as a bad form of cancer. And we collectively would never think of withholding therapy on someone with lung cancer, breast cancer, God forbid, but it happens all the time with a foot problem. Folks say, oh, that guy, Mr. Sanchez, he's got a sore, he's just going to get another one, just cut the dang thing off and be done with it. And that, sometimes that's the best thing, but almost never. It's unusual now to have to happen. But that is still the natural order of things and the perceived truth in a lot of hospitals right now in the United States and certainly around the world. But collectively, we can make a difference. And it's not all about technology, it's a lot about team. So, but the good thing is now, where people are starting to take advantage of this. One of my friends, Des Bell, who's a podiatric surgeon, started something called Save a Limb, Save a Life, and it's a foundation, and there are foundations at community hospitals and communities all over the United States now, which is really starting to make a difference to raise awareness about this kind of thing. You'd never think there'd be a ribbon for feet in diabetes, but there you go. There it is. But what's this thing supposed to do? What's this tie supposed to bind? And it's supposed to bind teams, bring people together with the patient at the center. And all that, I've just talked about all the bad stuff now. By the way, everything else is good, pretty much, except at the very end, which is kind of bad, but then it gets good again, FYI. Just to kind of, but these 3 things seem to be true, these 3 words. However we put a team together, however you bake it, good things seem to happen. These data are borne out. They're borne out all over the United States and North America, and really in every inhabited continent now. And we see this. It's quite extraordinary. And almost any way that you put people together to manage the extremity in diabetes with physicians and surgeons and nurses, good things seem to happen. What matters is that people care about it. But there are probably better ways to put together a team than others. I mean, look at my Lakers. That's not a good way to put a team together when you compare to, say, the Spurs, right? I don't know, but there are probably better ways to do that. I didn't even get a good laugh. It's just because no one even cares about my freaking Lakers anymore. It's really so sad. How the mighty have freaking fallen. That's a problem. But here we go. Let's talk about this. Let's talk about the toe, and let's talk about the flow. So this seems to be true as well. That podiatric care of the foot seems to prolong the life of the extremity. this seems to be a truism. And looky here, these are data, I have it from some of my buddies who are now buddies who are Dukies, and from in North Carolina. And if you look here, about 1 million lives, folks who saw their podiatrist along with any other member of the diabetes team, any other clinician in the diabetes team, there was a net protective effect against amputation, anywhere from around 19% to over 60%. That's a crazy high number, any of those. And usually, the less you need something, when it comes to technology, the less you need something, often the better it works. In this case, the more you need it, the better it works, because when the chips are down and there are really bad problems, as you see here, the net protective effect over a 6-year period was higher. That's really something. So that's pretty good. This was duplicated again in a study that was led through the American Podiatric Medical Association that showed anywhere from a 60 to an 80% relative risk reduction, depending on how you looked at these data, over a 2-year period in about 60,000 folks as well. So these data are all in one direction. If someone just does really basic stuff, just looking at the feet and managing it on an outpatient basis, inpatient admissions are reduced dramatically, and amputations are reduced dramatically. When you reduce amputations, you reduce morbidity and mortality, and folks get back to being active and productive. It's a straight line, and these data are pretty clear now. So that's good, but from a policy sense. But what if you, let's pose this question, I think I have it in here. What if you actually took that away? What if you took, usually when you take something away, then usually people just figure out another way to make do. This happens all the time. Someone leaves a clinic or an office or whatever, they say, I'm out of here, this place is going to fall apart. What happens? It doesn't fall apart. People usually figure a way around it. We thought this would happen in Arizona when podiatric care was removed from Medicaid. It was called Access, euphemistically, in Arizona. But we thought that ultimately people would figure out a way to sort this out. In fact, we were really wrong when we looked at this. We looked at every Medicaid life, and after podiatric care was removed, it led to what we now call foot and wallet disease. But let's just look at this. What ended up happening was right after the announcement, there was a remarkable rise in hospital admissions for diabetic foot complications. I think most people, when they think of podiatric care, they would think of an ingrown toenail or heel spur or a bunion. These are things that are painful and they limit activity, but they're not going to cost you your leg. They don't really think about a lot of this other stuff that's going on that I've already talked about. But look at this. I mean, this is in one direction. You see overall access enrollment, which mirrors USA relative hospital admissions. There was a 37.5% increase in hospital admissions for diabetic foot infections. There was a 22.8%, I think, increase in overall length of stay. There was a 45% increase in mean charges. And check this out, for what we call, euphemistically to the statisticians, severe aggregate outcomes, which is sepsis, amputation, death, that increased by 50%. So these folks' feet really were killing them. Some people say my feet are killing me. These people's feet really were. So you see this. So we talk about what happens when you add it and what happens when you subtract it. These data now are in one direction. So that's foot care, that's the toe. What about the flow? Well, what's pretty nifty is that when we improve blood flow, that seems to prolong not only the life of the limb, but also life itself. It seems to be net protective against mortality, much in the way that a bypass of the heart is. So look at these data. These are data from my buddy Enio Falia, and you see here endovascular and open procedures compared to no procedures in a matched population over several years, and you see a pretty significant decrease in mortality or increase in survival, as it were, in this. So that's pretty cool. Well, what about if taking care of the toe works and taking care of flow works? What about two great takes that taste great together, right? What if you kind of mash them up? And that leads us to how we build a team, and that has led to what is now called the toe and flow model, which is where you take podiatric surgeons and vascular surgeons and you put them together. And this happens at our academic medical center. It's happened at many other academic medical centers, not the least of which is right here in Georgetown with Professor Steinberg. No, Professor Steinberg, Jing Chen. Boy, man, I can't believe that. Well done.
Thank you.
All right, yeah. What we now see is that this seems to make a big difference as well. When you put people together, they care about it. But this is a nice way, at its core, where you have two specialties literally on one service. And this is something that seems really simple on the outside, but it really, it's a lot harder than it seems. It's a little like herding cats to get different specialists to really, really work completely together on one service. And when that happens, a big difference is made. This is kind of for your right brain. You don't need to see this. We basically have now one call center, one pager. Instead of a foot hotline, it's a hot foot line that is engaged. And really, people run after this just like they run after a heart attack or a stroke in these hospitals. And this is happening not only in big teaching hospitals like ours, but also community hospitals around the country and frankly around the world. We have folks from 5 countries right now, 4, one just left back from Germany, that are trying to duplicate this in other parts of the world as well. So this is great, and it seems to make a difference in terms of numbers as well. You see these data from our unit. We saw a reduction of about 45% in high-level amputations. That's not unusual compared to other studies, but what was pretty darn cool was that it fundamentally changed the approach surgically from procedures that were reactive and ablative, meaning like amputations that were emergency kind of procedures, changed them fundamentally to proactive and reconstructive procedures that were less acute and that were designed not to remove something, but to prolong something, to get people out living their lives, hopefully at home or on the job. So that was great, and these data now have been recapitulated by other teams around the country and around the world. So there's all that, but let me just, before we close, I'm going to just show you this. This is the first surgery, I don't know if you guys can see this, ever caught on tape. This is Professor von Bergmann. I just lectured not too long ago at there's a clinic named after him in Potsdam, in Germany. Check this out, especially while you're eating. It's not that gross. And you guys can put up with it. So look at him go. Boom, there he goes. That's got to be the first year student. He's so excited to be there. That's got to be the quality control nurse. She's upset that professor's not wearing gloves. I guess he didn't get the message from Lister. Anyway, she's happy to turn the room over so quickly. But the bottom line is that this is in 1901. And so, in many ways, while so much has changed, so little has changed. Because a man or a woman having his or her leg off back in the day, 115 years ago, probably had a better outlook on life than someone right now having his or her leg off in 2016. And I think we collectively can do better. So with that, when I think about that, my mind immediately turns to the Senate and naturally to the late great Senator Moynihan. Now, whatever your political stripes, this was a man who was extremely, shall we say, progressive, but he was one of the great men or women of the Senate. I think there's no argument there, and one of the great thinkers. And he had one of the greatest quotes I can think about, because it marries to what you guys deal with every single day, kind of triaging all this stuff. And he said back in the day that we live in a world of competing solves. Now, that is right up your alley, because folks are always coming to you, and everyone's problem is like the most important problem. And for them, or for anyone, it's like the biggest deal. And these things all have to compete with one another. So someone has to make something worse than something else to kind of get up from being 11th on the 10 most important things on the list. But that may or may not be true, but I think we can collectively understand that what we're talking about certainly is a sorrow, and it's a sorrow that we can address. But let's continue our friendly or unfriendly competition with cancer. We talked about that already, about how this is on par with a really bad form of cancer. God bless you. That was a good one, man. By the way, do you guys even trust those little ones? Because I do not. I wonder what's going on behind those guys and gals' eyes. Probably not a lot. Try out those people with a totally, do you have a crew desk? No. See? That's brilliant right there. So anyway, that cancer. So let's talk now about this before we close. Dr. Steinberg, I'm sorry. Through the chair. So let's look at these drugs that have been developed over the last 20 years. I just picked a number, 20 years. There's a lot. How many drugs do you think have been developed over the last 20 years? FDA approved? It's been a lot. I just looked this up, actually. I didn't even know. You guys are probably going to come up with a number that, okay. It's a lot. You guys can you see that? No, you can't. Oh, dang it. There's not enough resolution on this screen to show you the fact that it goes from here all the way down to here. But FYI is a lot. There's about 200. So that's a lot of drugs to go through the FDA, which is a hard process. It's an important process. But how many FDA-approved drugs do you think have been approved for diabetic foot, which is about as big as a lot of these forms of cancer? How many do you think? There's about 200 of these. Yeah, you guys are close. At one. And that was a Kaplan in 1997. I looked it up. I remember it because I was one of the principal investigators on the study back in the day. I don't have much hair, but it was kind of bountiful back then. And it was very, very exciting time. But that's been it. And there's a black box warning around this one because so it's really there's really zero. So you guys were actually right. So this is a big deal because there's very few places where you have such an enormous public health problem and that's the definition that the healthcare people call an unmet need, or business people might call an unmet need. This is the definition. You could drive a truck through it. So just last week, I think you all know that President Obama went to Cuba. We were in Cuba I've been many times over the last 10 years. And there is a drug there that's interesting, FYI, that is a growth factor. And data there for that seem to show that it may actually have a net protective effect on morbidity and mortality for it to heal wounds. Now, it's been used now on thousands of patients. But what we want to try to do for the last 10 years is try to bring it in here bring it into clinical trials, because it may or may not work. I think the data seem to be really promising, but we just want to give it a good shot through FDA. And I'm excited to say we're getting real close, frankly. And this will be number 2 as we march to parity in 200 in this problem that you guys probably never thought about, but now might think about a little bit more. So with that, what I'll tell you is I'll just conclude, Mr. Chair, ladies and gentlemen, through the chair, with this. Wouldn't it be great if we can pay a little more attention to this massive problem and this massive unmet need, and heal wounds of the past? We're talking about Cuba, by healing wounds in the future, and I think that's probably a pretty great thing. But I also believe, and you can hear about this from Dr. Steinberg as well, that you hear from a patient that once you've treated them, you're married to them. And that term marriage is often used in a pejorative way, in a negative way. But I look on marriage as a sacred institution. And it's one that's fraught with its ups and downs. But hopefully, with a little bit of communication, we can make a difference in preserving that leg and keeping people being active and productive. And I think that marriage between academia and public policy and industry is also sacred. It's a little polygamous, but there you go. And I'm just south of Utah. But with that, I also have tenure. Before you get the idea. But the bottom line is I think we can make a difference in keeping a few more legs on a few more bodies, because I think that's what we all deserve, whether we have diabetes or not. Ladies and gentlemen, thank you very much.